other things that we monitor when people that are on therapy. So we mentioned viral load, it's critical. CD4, important, but less often. And once you get above a level, we probably don't need to do it. What other things are we watching people for, Colleen?
Or periodically monitoring kidney function and liver function. And then going back to HIV as a sexually transmitted infection, we need to be monitoring for other sexually transmitted infections frequently in folks who are still engaging in behavior that puts them at risk. So in men who have sex with men, remembering oral and rectal STDs in addition to urethral STDs and syphilis.
Big one, right? Sure.
And Hep C.
And Hep C, of course.
There's been more and more evidence that even though we didn't originally think of hepatitis C as a sexually transmitted virus, certainly it is among MSM. And some people would monitor liver function tests, not because they're worried about toxicity of the drugs over time, but as an index that there might be HCV infection, although you could simply monitor for HCV.
Yeah, and that is recommended yearly in folks at risk. So.
Right. Lipids, Eric?
Yeah, so I think I tend to think of our our management of lipids in this population like we do everybody else.
Sure.
Yes, HIV affects lipids. Yes, some of our antiretroviral therapies affect lipids more than others, but mostly those differences are relatively modest, and that I just manage patients like I would. If they didn't have HIV, I do it at baseline. If they're starting on a regimen that I think will have a profound effect on lipids and they're already borderline, maybe I'll do it again after they start therapy. I think the HIV management guidelines talk about doing that.
Right, yeah.
But clinically, the drugs we use have such modest effects on lipids that it just rarely makes a difference. So I think we monitor them the same way, and we use the traditional guidelines for initiation of things like statins, although there's a lot of interest in HIV being an independent risk factor and a large randomized controlled trial that's looking to address that.
I think that's a really important message, and is we should be monitoring them as if they were healthy individuals with HIV. So those things like colonoscopy, right?
Cancer screening.
Cancer screening, mammograms.
Well, I guess, so talking about cancer screening, one area we didn't really touch on is around HPV disease, right? So even with antiretroviral therapy, we still have to be worried in both men and women about screening for cervical cancer in women and screening for anal cancer or abnormalities, dysplasia in men and women who are HIV infected because of the risk associated with HPV infection.
Yeah, that's a really important point. So what about this? We have this big population of people in care who are suppressed. And that's most of the people that come to see me. What about switching their therapy? What are reasons to kind of switch things up, Colleen? We heard that if it ain't broke, don't fix it, but maybe there are reasons to fix it or at least tinker with it.
Yeah, so I think when things like lipid abnormalities or renal disease, crop up with time as people age and have other comorbidities like diabetes and hypertension, where renal disease is very important. I think those are times where we, want to make sure someone is on, the least renal toxic medication or the most lipid-friendly medications, and we might consider, switching their regimen at that point. Another place where we're often switching is when people are hospitalized, either for HIV-related disease or non-HIV-related disease, and they need new medications, chemotherapy, anticoagulants, rifamycins, any number of things. We're often left with, well, it's not going to work with this regimen, and so we need to find something that it will work with. And then sometimes people just want to take less pills, or take something smaller, or sometimes patients have side effects, real or not, that they want to switch for. And so those are the situations where I'm generally switching.
Yeah, so talk about that, Eric. The desire to get someone maybe on their simplest, most effective regimen. Is that a goal for you, or when you?
Yeah,
I see it as a challenge.
Yeah.
Sometimes.
Well, we have, like you say, the majority of the people we're engaging are the ones who are doing well in therapy, and I feel like my obligation, and this is what I tell them, is the reason that they should come back and see me at all, because sometimes it's hard to convince them. People who are working, it's like, my viral load's always undetected, my T cells are high, and you always pat me on the back, is to do the sort of the health maintenance stuff that we still need to do, vaccinations, cancer screening, lipids, blood pressure, and all of that. But the other one is so that we can keep them up to date in a rapidly evolving field and let them know about new options that are available. And depending on that person, that new option may be really important. And I may say, you know what, I think this really is important for you to switch to.
Right.
You have osteopenia. I think getting you off TDF on TAF is really important.
Right.
Others, it's, you're on a 2 or 3 pill a day regimen, you're doing great, you're having no side effects. You need to know there's now a small 1 pill a day option. And I believe that you could safely switch to this if you want to. So I think that's a big part of what we do. We've defined the really important switches based on underlying toxicities or comorbidities, and those people who, for discretionary reasons, may want to switch. And we always remind people that there's always a risk of switching.
Sure, right.
But the risks are small.
Yep.
New side effects and things like that. Virologic failure we always talk about as a risk, but in reality, if we do this carefully, that's not going to happen. Right. Yeah.